Aye. All right, so which part is first?
Okay.
Lecture first. Okay.
That's something after.
Good morning.
Morning.
Morning, hi.
Coffee. Everybody seems to have. Oh, yeah. All right, summer conference. Which one is it? It's my conference. Yeah,
Not really.
I mean, typically, yeah. I'm more of like a cheap person or than anything, so I'll see. Even my phone, look, this guy, iPhone 6.
That's impressive.
Just because I gotta be an ecosystem, but otherwise,
Can you, I feel like there's newer iPhones that are used, that you get for pretty cheap though.
yeah,
So why
this one was used too. The
What's
used
the price difference between like a used 6 and like a used, let's say, 12?
a couple $100,
Oh, really?
which is not substantial, but like if you're gonna drop it all the time, you don't feel as bad.
Hey guys, is one of you around to let me in?
Yeah.
Forgot my badge. I'm by the back, by the.
Ken, do you want to? Yeah. He's by the back.
Not by the OR, the other door.
The
I can let him in.
by the back parking
He
lot.
knows, yeah. I get it. You can start it.
It's quite crippling if you don't have your badge.
Yeah.
It's like, you're dead.
Yeah.
It's waiting, hey buddy.
It's just.
But finally I see like David running, I'm like, David, and.
Um,
I'm gonna have to walk around. All right, go for it.
Okay. Good morning, everyone. I'm David Singh, one of the current fellows. Thanks for joining us for
GPT.
this morning conference. Briefly, going to just try to review some topics relevant to the concept of AI and its applications in spine surgery. This is not a technical talk by any means, kind of poorly organized bunch of ideas that I find interesting I wanted to talk about. So briefly speaking, I'm not going to go into details about what AI is, but it's an umbrella term that encompasses a lot of different advances in understanding data. But if we break it down into sort of the building blocks, much like how cells are our building blocks in biology, can distill data into sort of three big types that most applications are working on. That involves text, audio, and video. And with the analysis of these kind of three data types, we arrive at the applications that we see today. This data, initially a lot of the training on these data were from various different types of sources, obviously pictures online, using surveys to collect data, observations, in very similar ways of approaching how we collect data in the clinical setting. But it's kind of, if you ask someone in tech world what they work in and they say they do something AI related, it's typically in some subdomain that can be categorized with a little bit more generalizability. Machine learning is a catch-all term of basically working on some kind of software or algorithm that aims to either predict or classify groups of data. A subset of this that has really taken off is something called deep learning, which is a specific type of algorithm using neural networks. And they've made great advances in the accuracy and looking at vision, speech, and other forms of pattern recognition. The concept of data science is simply just how do we efficiently store a large amount of data and analyze it in a way that makes data pipe flows and structuring data collection to be useful, and visualizing this and drawing conclusions from it. Robotics has been around forever and has made some advances, but we're seeing advances in robotics now because of these other domains. Obviously, natural language processing is kind of the concept of reading words and making sense of them by deconstructing language down to its blocks of starting with just individual letters, forming stems in words, to then understanding words together and phrases and sentences. And these chatbots we see nowadays basically are advanced models using natural language processing with the idea that all they're doing is predicting what one word comes after the other. So back, probably 5-10 years ago, some of us might remember playing with the autocomplete in our text and our email, and it was wildly silly. But this is kind of just several evolutions down the line now. What is AI? Just a brief history. This is kind of the common framework of what a neural net looks like, having multiple layers. But essentially, this deep learning neural net stuff is a black box between what we input and what we see in the output. I think it's nice to just look over some popular influential figures. So these three guys are kind of known as the godfathers of AI: Yann LeCun, Geoff Hinton, and Yoshua Bengio. Just like acknowledging our godfathers in spine, I think it's important to understand where they came from in the process of, several years ago, what the field looked like to what it is now. And AI as a whole is kind of young compared to spine surgery. We look at a lot of our modern techniques, ACDF is in the 50s, but other than that, a lot of what we do now with screws and minimally invasive stuff came, late 80s to early 90s. But going over what these guys kind of accomplished, this is Geoff Hinton. He was kind of one of the pioneers as a professor of computer science in Toronto, and really pushed for neural networks back in the 70s when there was no funding available for it because they thought it was a stupid idea. So he was one of these guys who, pushed through with this idea, even though everyone was telling him he was stupid at conferences, essentially. His biggest paper and influence was about backpropagation, which is essentially when you put in an input and the desired output is incorrect, you give it a weighting of an error score, and it then takes the error score and goes back and tries to alter its algorithm to improve the error score. And it has this gradient of trying to optimize its function. So it's essentially like being in the OR with eSlack when he's telling you to burr something and you immediately get the error feedback. In some ways, all these godfathers have been really closely followed for their opinions on AI. He eventually went on to work with Google and recently retired just last year. He was sensationalized by media saying that AI is going to be dangerous. But in essence, he wrote his own blog saying, yeah, it's not more intelligence right now, but I think it may soon be. But also, I'm just retiring is why I'm quitting. Yann LeCun did his postdoc under Geoff Hinton and started his own lab in NYU and later on joined Meta and has been a key driver of a lot of their advancements. His, kind of fame in the computer science world had to do with pattern vision recognition with handwritten numbers. So he generated this huge set of handwritten numbers collected, and then basically published the series of papers looking at different algorithms. And if you look at his website where he posts kind of the lineage, just starting with the error rate of 12%, getting it down to 0.35% over 15 years or so. This is a huge advancement. Back in the 90s, banks started using this to read checks when you deposit online. But it's not too similar from some of the outcome data we see in spine surgery, where you see this slow advancement and incremental advancements over time with small modifications. But you can see how he went from traditional kind of linear classifiers, just like a linear regression model, similar to what we see mostly, and then moving through the world of convolutional nets to improve on the score. He's just made a lot of headlines getting in the online tiff with Elon Musk, basically claiming that he's a crazy ass conspiracy theorist. And Elon Musk was trying to engage with him, saying he was soft. So that's also something we're familiar with our seniors telling us in spine. So he's also commented about AI, saying that regulation is going to prevent us from making advances. It's way too early to think about it as existential risk. So this was as recently as a few weeks ago. So he's an advocate for less government intervention. And then finally, Yasha Bengio, and he's the most cited computer scientist in the world. Him and the two others wrote this paper on deep learning that's widely cited. He did a lot of work in speech recognition. Some people also sensationalize that he feels lost, but he just thinks it's a really complicated matter in terms of the existential risk. And down this lineage, this is one of my favorite influencers back when I was really in medical school, really interested in this topic. He did his undergrad with Geoff Hinton and then went on to do a PhD at Stanford in the computer vision lab. After that, he joined OpenAI. Back then, it was just trying to look at the sort of morality and ethics of AI applications. He then went on to the senior director at Tesla and led the team that created the Tesla autopilot that eventually improved into what the full self-driving mode is today. And then he joined OpenAI to launch ChatGPT. So he's really had a huge influence. But back before all this, in his grad school days, he launched a very popular blog online where he was just kind of translating what advances in AI were to average nerds like me. So basically breaking down what a neural network is, what it looks like from the computer backend, how it generates features from these pictures and then tries to group these features together in a very eerie way, and then basically how face recognition became one of the first applications that was really successful. And to make this really understandable, he trained a huge data set of selfies off Instagram back then using the error scores, how many likes or comments there were on the Instagram. And then he categorized it and told the neural net to find what makes a good selfie. So these were his conclusions, be female, don't show your forehead, show long hair, put filters on it, add a small border. And then he made a bot and posted this on Twitter and saying it only took 150 lines of code to make this bot, but essentially you can tweet your picture at the bot and it'll tell you what the score is overall. So you can kind of benchmark yourself and know if your selfie is good or not. And I think this is a perfect example of what makes AI good. So if you're going to think about how to find uses in AI and spine, you have to follow the same essentially examples. So you have to have a well-defined question, and you have to have a lot of relevant data for these algorithms to train on. So unfortunately for us, when we have a couple hundred patients in each study from whatever spine study group, it's good for finding trends, but it's not enough to really define these parameters of best practices. A lot of times you get non-modifiable risk factors. If you're a guy trying to glean from this data about how to make a good selfie, you're not going to be using this data to help you. But there are always modifiable things that you can improve upon in your work. And then lastly, we have to be able to benchmark performance. There's no easy way right now to know how does one surgeon do compared to another, other than kind of, their reputation, how their patients like them. And oftentimes that just has more to do with their bedside manner than anything. He posted a recent article, an updated article about 2 years ago about what's the difference in neural nets 33 years ago when Jan LeCun first published backpropagation 1909 to now. And essentially his comments are, we have access to more data now and we have more access to hardware. So the algorithm and the tech hasn't improved that much. It's just been sort of the application. And you can really see that with NVIDIA today. Their GPUs were the hardware building block to process these type of neural network data. So it's really exploded over the years, and that's what's driven the improvement in AI.
Did you show us the trends there in Mexican pesos?
Yes, I made this when I was in Mexico.
That's
So
awesome.
it was I couldn't figure out how to reverse it.
18,000?
Yeah.
So wait.
So in terms of computer vision, this is what a basic classifier looks like that people have been working on. In some ways that they've been doing this in spine, things like bone age have been more or less solved, trying to accurately predict the rough framework of how old your bone is. But even simple things like rotating the picture or changing the contrast or brightness, these are things you have to pre-process for to really make sure the algorithm understands it. Even things like radiographic markers, like the left, right, or the radiology text initials, that can actually affect the algorithm a little bit. So it's not perfect. And the common sense part of it is still hard. So even rotating the X-ray can still be a little bit challenging, but by and large, it's pretty accurate with the AUC of 0.844, which, isn't perfect, but gives you a rough idea. Say if you're a pediatrician and want to know, should you send someone for a scoliosis evaluation, for example. There is a nice Radiology Institute database looking at different applications of AI in radiology, which has really taken off based on computer vision. So real quickly, some of the ones they list. GE has been launching some post-processing CT software to label all the levels and find end plates. And also looking at a 3D model to try to center the axis of gantry to be perfect at every level. So these are small little things that'll make life easier for us, not so much helpful for radiologists necessarily. Fracture detection, this company called AI Doc, looking at CTs of the C-spine specifically, achieving pretty good recognition at certain slices, what's normal, what's abnormal, which is pretty hard. Degenerative necks can all look quite different. Vertebral compression fractures have also been worked on. SpineCamp is looking at similar to what we see in SurgiMap, but trying to be more accurate, identifying end plates, and then finding differences between flexion extension films to quantify if there's instability or hints of pseudoarthrosis or what the adjacent segment's doing. UNID, clearly we've had some use with that, but their claim for machine learning is in predicting uninstrumented upper thoracic compensation after surgery, as well as how the pelvic tilt changes, which is based off of their validation studies based off of 20 cases. So it's relatively fresh still, I'd say, but definitely an interesting idea. And then Colombo is just trying to do more quantifiable segmentation stuff of all these little details that we comment on broadly in a degenerative picture, but trying to really quantify that in more detail in a way that we can study. So Moving on to robotics, that lay people think we just point at the spine and the robot does everything. In reality, finding the right question for the robot is really important. Just because you can make a robot to do something doesn't mean it's necessarily practical or useful. So this was one of my favorite channels. A guy, just hobbyist, just doing random things. He turned his garage into a studio to make robots, and here's him trying to cut his own hair 3 years ago. And really the biggest conclusion from something like this, you can see the top comment, balls of steel, bro. So some people like to, face challenges, fear at work. I think our guys are more rational, trying to, tough it out for 9 hours on a bike. I think that's probably safer than risking your, being scared in the OR about what your robot's going to do. Probably something like this is a more, relevant, useful application of robots. It's not going to be as fancy, as sexy looking. It's not going to raise as many eyebrows, but these are the small problems that we deal with, wound care, ulcers, and turning patients in the hospital that really could make a difference for our patients. In terms of natural language processing, applications in spine, this was something I was interested in. I published in 2017, basically telling an algorithm to read every spine article in 5 different spine journals, spanning over 38 years. And I told it to find topics. So essentially it looks at how often certain words come up together in abstracts. And from there is able to define topics that trended over time. So you can see things like this red line here was the total disc replacement. So it's a good example of how it really took off in the 2000s. With MIS and pedicle screws taking off in the mid to late 90s. So just from a medical student perspective, interested in research, it was helpful for me to understand what people have been studying over time and what these different terms are, just so that when I went into clinical stuff, it wasn't the first time I've heard of certain concepts. What is the future of AI for spine? Right now people are doing a lot of stuff in the operating room. I think it's the fancy thing. A lot of this tech you see in this picture over here, wasn't the 3D C-arm and the augmented reality stuff is definitely new. Is all that going to kind of, combining all these screens and this hardware, is it going to just look like a headset in the future? Maybe, but right now it's just kind of a proof of concept. Or is AI just going to be kind of something useful for marketing that you can link to your website and show that you're, in the cutting edge of things? In practicality, it seems like a lot of tech and spine has gone that way. Or, is it just going to be some kind of fun art tool that we use, that doesn't really help us, but can maybe, create certain ideas? So some of the more recent popular comments are, the future was supposed to be to free up our time from work so we could spend on higher pursuits. Instead, we created AI that makes art while we work. So art has been something that AI has really made a big venture into. And this is similar to something Karpathy said in 2016, that we were supposed to make AI do all the work and we play games, but instead we do all the work and the AI is playing games. That was back when they were benchmarking AI on like Go and chess and other games to see if how it could benefit us. So, briefly, AI needs to solve a few questions before we can make it into spine. What's the cost benefit of all this new technology? That's why we need people like Dr. Malone looking into these topics of when is there clinical benefit and what does technology need to get to before it's useful? The generalizability of AI, so training chest X-ray and Framingham study on CT scans. For heart, can we use that data set for orthopedic applications? Looking at quality assurance and being able to adjust it over time, thinking about how we make this work for our end users, not just us, but other people in the pipeline. Publishing to understand really how to trust different AIs when we can't see inside the black box, understanding the different stakeholders in terms of cost and how it builds into our existing IT and other hidden costs down the line, both financially and also just with time. Legally, anything that an AI is saying on behalf of you, you're responsible for. So Air Canada had a chatbot that was hallucinating and making up its own refund policy. And they ended up judging in court that they had to honor the refund policy, which was kind of funny. But you can imagine similar situations for us if we start to leverage tech. And then finally, the gold standard for us is understanding level 1 evidence, which is starting to come out in radiology journals with stuff like skeletal age, but that's takes a huge amount of time and resources to make it as well. And then agreeing upon definitions amongst clinicians. If we were going to identify what AI should classify, we have to be able to tell it in the first place how we label the data. So is a non-displaced plateau fracture versus just a osteoporotic fragility, failure, and end plate deformity type question. Like what is it looking for? It's up for us to tell. Finally, the edge cases are always notoriously hard for AI. So AUC of 86% or even 90% is great, but we all know that we see things that happen less than 10% of the time that we really have to look and think about that don't fall into these big boxes. So that in itself is going to be the biggest challenge of weeding out when AI can't see these things. And lastly, we already get some of this right now with notification overload, secure chatting all the time, but how do we be better stewards of, in the ICU, all the different alarms that go off and how to not fatigue our attention. I just want to conclude with things I think we're bad at, not from an AI standpoint, but just overall things where I think there might be opportunity in the next 5 years that may change the way we deliver medicine. So in responding to patients, Google's made this Amy chatbot. They always name it after women for whatever reason, but in grading it, so they're grading it on how it responds to certain patient complaints. So just like a nurse triage nurse would respond, and they thought, according to specialist physicians, that most people graded it with a high degree of empathy, even more so than general doctors. But this is just an early study. NVIDIA has announced a partnership with Socratic AI on developing these avatars. So not only is it a text box now, it's a face that talks and looks at you, makes eye contact and smiles and changes their expression when they hear you talking and things like that. So really scary, but hey, it's $9 an hour. So, it's cheaper than hiring a nurse, right? And I'm sure there's, certain redundant questions that we get called about there are applications now where you can literally send it a video and then it can make an avatar of you. So, say Darcy or Cindy, like you could just film them, having a conversation with the patient. Theoretically, it should get close enough to start answering stuff. So scary, but like this is the kind of stuff that I think we are all short on time with. Some of the comments on these announcements on Reddit, I think it's pretty funny. Some people are going to always say AI is not going to replace what a nurse does in person. Whereas other people are like, I can't wait for AI doctors. I'm a patient. I'm so sick of human MDs and they're bullshit. I just want to get treatments without mistakes, please. Like every one of us can visualize a patient we saw in clinic with this attitude. So, in some ways, this may be an application that can help those types of people. Writing notes, I know I'm terrible at it.
The doctors are also $9 an hour.
The residents, especially.
Or they will be.
So this is a funny prompt I saw posted. Someone asked ChatGPT, what are the 20 jobs you're most likely to replace humans ranked, and tell us why you're better than humans and give us a probability. So in the top 10, medical transcriptionist was number 6. I know I'm terrible at writing notes. I know I wish when I went back, I could kind of interpret what I was thinking better. So they're working on a lot of these things that can listen to your conversation and structure it in whatever template you want. And, the statistics on the time saved is pretty compelling, how much of the time we don't spend on actual patient care versus documentation, and how much that adds up over time to our system. They've got a nice demo interface that shows you how it really templates things, and you can break down by section. Organizing text data like this is also a huge goldmine for stuff like, natural language processing in the future, or going back and looking at data in your consult for research questions. So this is all stuff I think we can see would be nice to have, but how much does it cost to do and to check over all the work is often right now probably more so than it's worth. What are we bad at? Filling out forms is also terrible. For better or worse, some with good reason. Nothing that slows down clinic should be done at the time. Hard to do that when there's 3 patients waiting for you to be seen and they're angry. But stuff like disability insurance auth, if we can have it automatically fill out 90% of what it has with information we have digitalized and filling out parts of what we do, I think that's a quality of life thing for us. And data entry clerk does make sense to be, copying forms and one into another. It's a huge application that hopefully we'll see uses of. Other things that I struggle with personally in decision making that there may be help for, what's the pain generator? Dr. Uselak's asking me. I don't know. How do we know if things are urgent or non-urgent? That 1% where the medicine doctor really shouldn't send it out. When is the right time to intervene? Dr. Mundis always talks about this inflection point. It seems like he can see it in his graph when he's talking to patient, whereas I can't. Dosing narcotics is extremely frustrating. We have patients in-house right now or nothing seems to work. We have other patients. Dr. Bruffries over the weekend was like, I just took Tylenol, I feel great. And it's like they had the same surgery almost. So what's going on there? Follow-up timing, I think the 1 month, 3 month, 6 month, there's definitely some people who need to be seen sooner, some that don't need to be seen as much and are sitting there like, why am I here? Wound monitoring, they all heal different rates. Skin heals with different types of scar. So what's normal? That's hard. Even with people looking at it for decades, it's not always easy to know. We throw PO antibiotics a little threshold, but there's probably something more in that we don't understand. How many levels to fuse in surgery is really hard, knowing what subjectively how bone feels. I definitely feel like the Evenity and the bone augmentation stuff does seem to make a difference after feeling enough treated versus non-treated patients. Probably the most frustrating thing for me is nerves. We had cases this year where you do everything normal, you spin after, you look at a CT, everything looks normal. And I think this has happened to every single surgeon that I've worked with. So very frustrating to understand, not sure how to counsel them on recovery. Spinal cord injury, similarly, even more devastating with the centralized sensitization issues also post-op. And then finally, like myelopathy, we have this MJOA, which is a very crude measure, but there's still a lot we don't understand. So bridging the gap between the time course and it's a plug for, if you haven't heard about bridging the gap, check it out. But other people are working on these problems outside of what we know. Neuralink is a cool brain-computer interface that's been making a lot of news recently with a spinal cord injury patient who's been, I think he was the C5 level, who's able to control a computer with a brain chip implanted in his brain, able to play chess and do things. So that's created a lot of excitement. And, I think we've looked at spinal cord stimulators as a way to alter the pain pathway. So is there something, opportunity for us to implant something in the future that understands the signals of the spinal cord? This is happening now, and they've been doing animal trials for quite a long time. So I think there's a lot of data that we can start collecting on these patients that may help us understand better soon. Other workarounds, exoskeletons, people trying to redirect muscle innervation pathways to controlling motors. I think that's also a subject we don't see very much, but could provide a lot of benefit in the rehab protocol, not just for spinal cord injury patients, but patients who wake up with weakness. So in conclusion, there's definitely a need for things like AI to figure stuff out that we don't understand still. I think we have all the technology we need in terms of hardware and software to solve some of these questions. The hard part right now is getting enough quality, high quality data that's relevant to the questions we're asking. I think that's a problem a lot of the times for software people working on the outside looking in, making these fancy robots and applications to solve questions that don't really create a big problem for us. And finally, the stakeholders. So anytime you ask for something new, someone's going to be like, well, you're adding costs for what benefit if you can have a resident do it or have a fellow do it, or how is this cheaper than what we're doing right now? And it's hard to measure what's better for the patients and for the healthcare system overall. And that's where this concept of it's better for marketing sometimes is driving the tech more so than anything else. So I'd like to also give a quick shout out to my buddy Paul Yee. He's done a lot of work in fracture diagnosis and radiology. He has his own podcast he's running. I talked to him a lot about this stuff, so he kind of keeps me up to date. This is some of the slides borrowed from him as well. Thanks.
Really cool. Awesome job. Dude.
Yeah, fun topic. We're a few minutes over, but like, it'll be a fun discussion. It'll take a few minutes to, you guys have any thought?
Yeah, I'd say, so it's happening in the areas that are financially beneficial as we speak. There are bots that are helping with auth and things like that. So I think it'll be slow to move into the high liability arena part of medicine, but absolutely necessary. And as HR gets more expensive, nursing care, stuff like that, just like we deployed force to try to reduce some of the burden on them, I'm sure it will move into a lot of the areas of medicine that require algorithmic thinking more accurately, and there's not a need for procedural engagement. So I think it's gonna consume a lot of the primary care and internal medicine, non-procedural stuff that we do in healthcare, radiology. That's already there. I mean, they already do mammography analysis and done much better.
Yeah, it needs to take over radiology, I think.
It will.
And because it'll take
Perfect for radio.
Yeah, because it takes the subjectivity of one interpretation over the other, right? Just like, here's what's there. And this one.
Yeah, I'd be very afraid if I was a radiologist coming out of training right now.
You gotta go interventional or do something different.
Yeah.
Your job's not gonna be around very long.
So is it just gonna be like our AI arguing with an insurance company AI over authorization? They're just gonna be
Well,
like
I mean,
bickering
So
back.
so here's a real silly, simple example on the front end. Our intake. But when we have people call in to see anybody in our group, they interface with a human being who's trying to read these algorithms to put people in the right slots. Huge human error factor, right? I bet 10-20% of the time they get it wrong at least. Down to 0.3% would be an enormous win for just our patient care. On the AI side for auth, we have the same issues. We're trying to keep up with insurance companies that have unique needs for the auth process, whereas the bot system it'll automatically be updated, understand and know what it needs to deliver by insurance company, by diagnosis, and do that seamlessly over minutes versus weeks of back and forth because we didn't know what to put in the note. The auth people don't know what the insurance company requires.
Yeah.
Makes sense. So it'll streamline efficiency on those.
I think at some
Very
point,
simple thing.
all this crap's gonna go away because it's all artificial to begin with. Like, it's gonna come down to,
Yeah.
it's like if one computer's talking to another computer, if you're saying,
It's like
what's the
circle. We've
Yeah.
made it so complex and now it's
Yeah.
like, well, we'll just let the AIs handle it.
Yeah.
And then they'll just,
It'll simplify some.
it's about to get weird.
So like just a general question, David, like the word or the topic artificial intelligence, I struggle with that because to me, that means there's something intelligent. Like none of this stuff is intelligent to me. This stuff is simply data fed into a system that's put into an algorithm that then spits out probabilities. Right? That's not
Machine
really
learning.
it's machine learning. It's not true, like, but I understand how it falls underneath it. Like, is there something, because to me, AI would be X-ray, it gets the clinical note that was seen and then provides interpretation based off the unique features, right? Or something like that, where like comes up with its own.
That's the highest level though. Okay, that's the next
Yeah,
step.
but that's really what AI is, right? Rest of it's just like data put into a system, like.
Yeah, one of the comments I read was that right now AI is no smarter than a household cat, right? Like a household cat can put together concepts better than an AI can. AI can do things a cat can't do, But from the concept of generalized or AGIs, artificial generalized intelligence is the key term. It's like, when is it going to be able to tell itself what to do,
Right.
rather than being prompted what to do? There's at some threshold, it'll be considered, intelligent, but right now it's just really good at highly specific focused tasks. But the whole field has just been covered by media as this term AI, which, a lot of it's from movies and pop culture. So that's what the public is familiar with.
I think some of it's there though. Like I saw a video of AI responding to like inflection in people's voices and emotions and stuff during a video conversation. I don't know, that freaks me out. Like literally responding to someone's emotional voice and like changing their response and tone to that, which is like pretty close to non-algorithmic learning.
Emotional intelligence.
We're like, I don't know, a year or two into this whole thing.
Ollie's predicting the future right now. You can see the freaking robots taking over.
I told my
That's
wife last
fantastic.
night, I gotta start training our son to fight robots. Like, I feel like this is,
No, I agree.
this is how it starts. I shouldn't say that.
I think it's gonna happen.
Oh, yeah, I'm sorry.
Wouldn't it be bizarre if there's an AI that told like an autistic person, be like, that person's expressing sadness? Wouldn't that be bizarre, like a robot telling you about human emotion?
A robot therapist.
Like, feel
Well, like
sadness.
Anna Collegian had that
Yeah.
freaky
Think you're
deaky thing
sick?
come in here. Whatever that was disturbing.
1,000.
Yeah, but yeah, that was, I mean, that was a freaking Terminator, like, liquefy in front of me. I think it was ridiculous, the facial expression change.
Scribe.
It was AI inside of a doll.
Yeah. I don't like it already.
It looked like a doll with a knife. I was gonna like come back and, it was like, yeah, it's like Chucky.
Yeah, truck injection for you.
Don't move. All right, shall we switch over to the other? Thanks everyone for tuning in. We are gonna go ahead and sign out. We have to sign back into the other